Que coisa boa vê-los aqui, pós-período pandêmico. A gente vai retornando. Que bom ter vocês e que bom ter também a possibilidade de ter participantes de forma remota. Agradeço muitíssimo. Já aproveitando os agradecimentos, agradeço a Secretaria Municipal. Secretaria Municipal de Saúde, que está com a gente também, os colegas, pós-graduandos, colegas da área, colegas da escola, funcionários. Ontem, a gente já agradecendo também as palestrantes de hoje, que coisa boa ter. Tudo bem? Já agradecendo a presença também das professoras Suzanne Campbell, da UBC, do Canadá. A professora Suzanne tem sido um ícone quando se trata de simulação, de aleitamento materno, de saúde da mulher, com livros premiados, inúmeros, e tem tido uma inserção importante. Deu aí? Tem sido bastante importante, e a nossa parceria, muitíssimo obrigada, de longa data já, e que a gente tem feito coisas muito interessantes, olhando para a simulação, para as tecnologias, para a simulação virtual. Hoje nós vamos trabalhar as competências, que também é uma vertente bastante importante da professora Suzanne. Muitíssimo obrigada. Thank you pela presença. E a professora Natália Del Ângelo Aredes. A professora Natália é professora adjunta da Faculdade de Enfermagem da Universidade Federal de Goiás e vice-diretora da faculdade. Nossa egressa, que orgulho ter você aqui. A professora Natália, ela é parte importante da história do nosso grupo de pesquisa, e tem parceria também, e que a gente é bastante produtivo nisso tudo. Agradeço muitíssimo pela pela possibilidade de estar aqui e ajudar nos nossos entraves de pesquisa. Então, nós vamos conversar um pouco sobre as competências na simulação e as pesquisas, né? O que a gente precisa aí de rigor de pesquisa, sim, se tratando da simulação. Para quem está de forma remota com a gente, nossas auxiliares de palco vão ajudar com as questões, então vocês podem escrever no chat e a gente vai ajudando aí para responder, ok? Nós pensamos em 3 momentos distintos das falas de hoje. Então, primeiro a professora Natália vai trabalhar um pouco das competências, contextualizando para o nosso espaço brasileiro. Depois a professora Suzanne vai trazer, né, o que tem aí de mais novo, olhando para as competências, em especial na simulação. E um terceiro momento sobre pesquisa em simulação. Okay? E aí do rigor e de tudo que eu disse antes. Agradeço muitíssimo a presença de todos, em especial de vocês, agradecendo ainda a pós-graduação, o programa de pós-graduação em saúde pública, pelo apoio ali, e o GPECA. Obrigada.
Bom dia a todos, a todas. É um carinho e um prazer imenso estar aqui de volta, né? E essa recepção, é muito bom abraçá-los. Eu estava com saudades, né? Nós não estivemos juntos no momento da pandemia. Nos vimos alguns, né, por videoconferência, em bancas, em Google Meet. Então, é um prazer imenso estar de volta aqui à casa, vê-los bem, com saúde. Então, fico muito feliz de ter essa oportunidade de estar aqui. Bom, eu vou primeiro falar um pouquinho sobre a estratégia. Há 6 anos, a professora Suzanne e eu fizemos uma palestra juntas, ambas falando em inglês, com a apresentação em inglês e em português. Enquanto ela falava em inglês, às vezes eu traduzia, voltava. Nós vamos tentar uma abordagem diferente, parecido com o pitch deck que nós fizemos ontem. Então, minha apresentação está em português, eu vou falar em português. A professora Suzanne tem a apresentação em inglês que eu traduzi para ela para acompanhar. Depois ela vai fazer a palestra em inglês, tem os slides em inglês, e se nós precisarmos de intermediação de tradução, né, quem tiver condições aqui junto, a gente vai fazendo e tem se comunicado bem. E a professora Suzanne está falando no espanhol, muy bien. Então ela consegue entender um pouco do português. De 6 anos para cá, ela já está, daqui 6 anos, quando voltar, vai estar fluente em português. Então a gente está tentando uma estratégia diferente dessa vez. Bom, eu vou falar um pouco sobre competências, um pouco desatachada da simulação no começo, para a professora Suzanne, de fato, falar sobre a aplicação das competências na simulação, e aí com enfoque da parte interprofissional, que é uma competência que nós temos que avançar muito ainda, embora a gente fale dela há muito tempo na área da saúde e na enfermagem. Primeiro, gostaria de agradecer, então, Lu, pelo convite, a pós-graduação por permitir esse momento, a escola de enfermagem que eu tenho no meu coração com muito carinho, enquanto o professor Pedro ontem nos recebendo, o GPECA, que é o grupo de pesquisa que continuo participando mesmo que indiretamente por meio das pesquisas, não das reuniões mais, né? Mas das pesquisas certamente, e estou muito feliz em conhecer os graduandos e pós-graduandos do GPECA, né, que estão nesse momento agora na escola. Também cumprimentar, a professora Luciana mencionou a pessoa da Secretaria Municipal de Saúde, quem que é que eu não me lembro. Olá, muito prazer. Professora Cândida, aliás, meus professores aqui queria um carinho muito especial, 15 de outubro foi muito em breve, muito há pouco tempo, então feliz dia dos professores, para as minhas queridas que aqui estão. Vou falar um pouco sobre as competências e vou falar um pouco sobre o ponto de vista, a perspectiva em que eu estou. A professora Luciana comentou, então, que eu estou na vice-direção da Faculdade de Enfermagem, da UFG. Nesse momento, nós estamos passando por uma mudança curricular importante, né, em relação tanto à inserção da extensão no currículo, que já estava prevista no Plano Nacional de Educação, mas também participando do NDE, que é o Núcleo Docente Estruturante. Então, nós temos nos debruçado sobre os estudos das diretrizes curriculares nacionais e da Resolução 573, que, por meio do Conselho Nacional de Saúde, fez uma parte já das intenções das novas diretrizes curriculares nacionais, que tinha previsão de ser publicado em 2019 e, por questões governamentais, ainda não foi. Então, há uma perspectiva de, quando passar a Resolução 573 do Conselho Nacional de Saúde no MEC, ela, enfim, for publicada como as novas diretrizes curriculares nacionais para a enfermagem. Desde as DCN 2001, nós temos sinalizações sobre competências, mas pouco discutimos sobre isso em profundidade. Na Resolução 573, essa discussão se ampliou, e nós precisamos falar um pouquinho mais sobre o que a gente entende por competências, e também tendo participado na escola como professora substituta no ano de 2017, eu lembro que tinha algumas discussões sobre as tendências pedagógicas em relação às competências. E aí é uma discussão bastante polêmica, de crítica ou a favor das competências, e o meu objetivo nessa apresentação super breve, que é a estrela da professora Suzanne, é a gente só limpar um pouquinho o rótulo de competências, e essa é a minha proposta. Queria saber quem que é da licenciatura originalmente aqui, ou tem algum envolvimento, seja na graduação ou como professor. Muito bom. Então, é justamente para a gente trazer isso, e eu conto com vocês se tiverem outras visões, perspectivas para a gente fazer a discussão, embora a minha promessa seja de ser uma apresentação breve, tá? Bom, então, a gente tem que falar um pouquinho sobre o que são competências, sobre o que se discute sobre as competências na educação e qual é o conteúdo de competências por detrás do rótulo. Por que eu estou falando disso, né? Nós temos uma discussão muito importante na literatura que está trazendo diferentes frentes. Uma falando a favor das competências, de que é uma forma objetiva e importante de avançar sobre os objetivos de aprendizagem que a gente tem para a formação do enfermeiro. Isso vai ficar muito claro quando a professora Suzanne falar da simulação. E uma outra vertente que diz que ela remete ao modelo tecnicista de formação, porque ela é pautada em objetivos. E aí remete, por exemplo, ao currículo como foi elaborado por Tyler, tradicionalmente, por disciplinas, com fragmentação, e é um pouquinho disso que eu queria conversar hoje. Antes de falar o que é competência, eu queria falar sobre o que não é competência. Tá? Então, a formação por competências, ela não é um modelo pedagógico, ela é um enfoque. Quando a gente parte desse pressuposto, nós estamos nos livrando da questão de dizer que ela não conversa com problematização, que ela não conversa com a tendência histórico-crítico-social dos conteúdos, do professor Saviani, né, que também é uma tendência progressista de educação. A gente limpa de que ela não conversa com o construtivismo. Então, quando a gente diz que ela não é uma tendência pedagógica, ela não compete com aquilo que a gente acredita, e que, inclusive, está no projeto pedagógico de curso dessa escola, né? Ela não se constitui na projeção de uma dimensão pragmática. Então, quando alguns estudiosos criticam as competências, o termo competências, ele aparece muitas vezes nas nossas diretrizes curriculares nacionais. Ele aparece na ICN, que é o Conselho Internacional de Enfermeiros, ele aparece nos textos de simulação, ele aparece tudo. E eu imagino que ele vai aparecer cada vez mais. Inclusive, tem um projeto que eu tenho participado agora na UFG, que foi uma encomenda do Ministério da Saúde sobre como que está o mapeamento de competências nos currículos de enfermagem do Brasil. Então, há um movimento de competência cada vez mais se consolidar. E é importante essa conversa nossa aqui para tirar um pouquinho o estigma sobre competências, né? Esse aqui é um autor que vai trazer a parte controversa, só para a gente entender do que eu estou falando. Né? Eu pus até um quote certinho, as aspas, do que tem se dito, que é um dos argumentos opostos à competência. Né? Então, ele diz que, no mundo atual, o aspecto instrucional da educação não consegue dar conta da profusão de conhecimentos disponíveis e emergentes, mesmo em áreas específicas do conhecimento. Por isso, ela não deveria preocupar-se tanto com os saberes instrumentais, privilegiando a capacidade de acessá-los, decodificá-los e manejá-los, e que o aspecto instrucional deveria estar em função da emergência do aprender, na emergência da substituição da pedagogia das competências e dos saberes pré-fixados por uma pedagogia da pergunta, do melhoramento das perguntas, do encantamento. O reencantamento da educação requer a união entre sensibilidade social e eficiência pedagógica. Portanto, o compromisso ético-político do educador deve manifestar-se primordialmente na excelência pedagógica e colaboração do próprio contexto escolar. Os textos, quando eles vão fazendo essa abordagem, inclusive mencionam Paulo Freire e trazem como uma oposição às competências. E eu passei noites pensando sobre isso, porque ele é meu principal referencial de educação. A gente trabalha com problematização, né? Que na escola a gente fala sobre ação, reflexão, ação. A gente fala sobre pautar o nosso ensino a partir da realidade que nós encontramos no SUS, das necessidades reais da nossa população em termos de saúde. E isso não está desconectado de competências. Eu pensei muito sobre isso e li muito texto para poder... Eu falei, gente, mas eu entendo que competência é algo importante, porque a gente não pode formar enfermeiros, por exemplo, sem ter um rol mínimo de competências, porque ele vai estar amanhã no serviço de saúde e ele tem que prestar uma assistência qualificada. Então, a problematização, ela não é opositora das competências, e eu consigo falar isso com muita tranquilidade hoje, depois de muito refletir sobre esse assunto, e é isso que eu queria propor aqui. Quando a gente vê, então, competência como algo paradoxal, a educação emancipadora, libertadora, de Paulo Freire, problematização, ou do professor Saviani, ou construtivista, Piaget, qualquer coisa, a gente não precisa ter essa marra. Esse é o ponto que eu gostaria de convencê-los nessa minha fala, né? Então, A pergunta é, competência é um paradoxo da educação libertadora, da educação humanista? Ela é dicotômica? Ela é contrária? Tem dois aspectos que diferenciam claramente a noção de competência numa perspectiva cognitivo-construtivista, né, crítica, da perspectiva tecnicista, que reproduz saberes sem pensar criticamente. São duas, né, segundo Lopes e Macedo. Uma é que as competências elas superam o modelo linear de entender a aprendizagem. Ela não está focada em objetivos simples. E eu acho que esse é o grande ponto de importância. A competência é algo muito maior. Então, ela não está focada no modelo linear de aprendizagem. E ela não é definida por esquemas. A gente tem os esquemas de Kolbe, por exemplo, que nos ajudam a entender os objetivos, mas a competência é algo maior que isso ainda. E a segunda é que toda competência é construída na prática social concreta. E esse é o ponto de confluência com a pedagogia crítica. As competências que os nossos estudantes de enfermagem desenvolvem nos cenários de prática, elas acontecem nesse espaço. Então, como que ela está desatachada da realidade social? Ou como que ela está desatachada da problematização? Se ela é feita neste contexto, então a gente pode validar a competência como um objetivo de aprendizagem macro, crítico e que é alcançado por meio da prática social. Então, o que não é competência? Ela não é reprodução de saberes sem reflexão crítica, ela não é paradoxal às tendências pedagógicas progressistas, ou seja, ela não está fatalmente alinhada à educação tradicional, ela não é a repaginação de objetivos de formação para fins de mercado, a não ser que a gente queira que ela seja, porque a competência é feita pelas escolas, é definida pelos professores, então é a partir da visão de mundo e da pedagogia que esses professores têm é que as competências são desenhadas. Por isso, o nosso papel é importantíssimo e das diretrizes curriculares nacionais, quando elas trazem a formação crítica dos enfermeiros, né? E ela não é aplicável apenas a saberes procedimentais. Ela não é só do fazer por fazer, que é uma preocupação que a gente sempre teve na enfermagem, de romper com isso. Ela é crítica e ela é maior, né? Então, o que é competência? Se a gente já falou do que não é competência, o que é competência afinal, né? Uma competência é um saber agir complexo que resulta da integração, mobilização e organização de um conjunto de capacidades e habilidades que podem ser da parte cognitiva, afetiva, psicomotora ou social, que tange as atitudes, né? Que a gente fala dos conhecimentos, habilidades e atitudes, e conhecimentos utilizados eficazmente em situações que possuem características em comum. É quando o estudante consegue consolidar um saber fazer, né, e um saber pensar sobre aquilo para resolver um problema a partir de um construto maior que ele desenvolveu de resolução de problemas, de pensamento crítico, né, e de reflexão sobre os problemas que aparecem. Esse é um dos conceitos de competência. E aí a gente tem dois caminhos, né? Se a competência é o conjunto de conhecimentos, habilidades e atitudes necessários para exercer uma ocupação e mobilizar e aplicar esses recursos num certo ambiente, numa certa situação, para produzir um resultado definido, de novo os críticos poderiam dizer, se é com um resultado definido, você não está encaixotando o estudante, a competência ela não é um recorte muito não crítico, muito específico, assim, muito num objetivo micro, depende de quem está montando e como está montando essa competência. A gente tem dois caminhos. Ou a gente monta competências para reproduzir saberes, que é o tecnicismo que a gente condena, né? O fazer por fazer, sem pensar sobre aquilo. Ou a gente pode trazer isso para uma tendência pedagógica crítica e libertadora para promover transformação social. Eu posso montar competências em diferentes tendências pedagógicas. Essas daqui são as tendências pedagógicas do professor Libânio, que a gente citava muito aqui na licenciatura. Eu tive o prazer de tirar uma foto com ele. Eu falei, professor, eu preciso tirar uma foto. Ele é da PUC de Goiás, eu não sabia, foi uma palestra, foi muito legal. Então, nós temos diferentes tendências, e o professor Libânio ele classifica como tradicional, que é aquela que o Paulo Freire denomina bancária, né? que o professor ele é o detentor do saber, ele é a centralidade de todo o processo. A renovada não diretiva, no Brasil a gente teve o movimento da escola nova, né, que trouxe o humanismo, mas também teve toda uma emolduração nos processos tradicionais que a gente já tem da escola, que são muito antigos, é difícil romper. Libertadora, que é quando Paulo Freire traz a reflexão sobre a busca da transformação social por meio da educação crítica, que emancipa os indivíduos. E a histórico-crítica, que o professor Saviani, né, faz uma reflexão de que nós precisamos nos utilizar do conhecimento que foi desenvolvido pela humanidade para então sermos emancipados. Então a gente pode preparar competências recortadas para o tradicional. Se eu coloco objetivos não críticos, eu posso fazer uma competência voltada para uma visão não crítica, tradicional, reprodutivista. Se eu quiser também colocar o pensamento crítico e elevar o nível da competência do estudante, do enfermeiro, para uma resolução de problemas que esteja voltada, né, que ele usa prática baseada em evidência, que ele tem pensamento crítico, reflexivo, eu consigo fazer isso também. Eu, como professor, quando digo eu, somos todos nós, né, nesse processo que participamos. Então, quando eu coloquei essa figura desse professor aqui, que nos remete a um tipo de tendência pedagógica. Se eu fosse perguntar para vocês, tradicional, né? E por que a gente fala tradicional? Ele está na frente dos alunos, ele tem uma figura de poder, de ser mais, e ele tem um semblante que muitos de nós temos herança de professores que tivemos ao longo da vida, que nos tolhiram, né, e que nós tínhamos uma perspectiva de punição pela avaliação, tudo aquilo que a gente sabe que permeia o processo educacional ainda. Mas eu posso fazer isso aqui, que é uma abordagem mais ativa. A gente diria que é uma abordagem mais ativa, né? E o ponto que eu quero trazer é, eu posso colocar esse professor em roda. Aí vai parecer que está super ativo, mas ele é o mesmo. Ele está bem ali, né? Então, eu posso ter um método ativo, mas se o professor tem uma tendência pedagógica tradicional, está parecendo uma coisa que não é. As competências, gente, a reflexão que eu quero trazer é exatamente essa. Quando tem a crítica da competência na educação, eu entendo. Porque ela pode ser travestida de um modelo tradicional com objetivos curtos que querem capacitar os enfermeiros para reproduzir alguns fazeres para fazer a máquina rodar, para interesses de mercado. Mas eu quero propor uma outra reflexão. Se a gente faz as competências no nível macro, que é como eu interpreto, que os pesquisadores de simulação fazem, que a ICN faz, que a Organização Mundial da Saúde faz, que a OPAS faz, quando está falando de competência, é da outra competência, essa competência crítica, que está alinhada às tendências pedagógicas progressistas, construtivistas, humanistas e críticas emancipadoras. Então, é possível adotar as competências no currículo e pautar a prática no modelo tradicional? É. Assim como aquele professor está em roda, mas ele continua sendo o professor que pune, que exerce poder e que se sente o único detentor do poder, né, e do saber. É possível utilizá-la numa perspectiva libertadora? Sem sombra de dúvida, né? A gente é só trazer o componente da criticidade, prática baseada em evidência, humanização, SUS, tudo aquilo que nos norteia a nossa prática, porque eu sei que aqui nessa escola é muito bem ensinado. E do que depende isso? De como são elaboradas as competências. Então, quando os currículos de enfermagem trazem as competências, quando na simulação a gente planeja quais competências pretende alcançar, a gente tem que pensar, elas são habilidades de reflexão crítica? Elas mesclam aos saberes cognitivos e procedimentos as atitudes também, numa perspectiva humanista? Eu estou valorizando outros saberes que não algo que pode ser checado numa prova de múltipla escolha? Eu estou equilibrando os diferentes saberes entre o cognitivo, a habilidade e a atitude, porque a gente precisa de um enfermeiro completo, né? Elas são flexíveis, essas competências? Como elas são elaboradas e revisadas? Eu estou considerando aquilo que eu vejo do meu estudante, o perfil do estudante? Em licenciatura a gente estuda muito isso. O perfil do estudante ele faz parte do planejamento do processo de ensino-aprendizagem. A gente está considerando isso nas competências e na simulação, e elas são de nível prescritivo ou norteador. Se a competência, mesmo numa perspectiva crítica, ela passar a ser prescritiva, talvez a gente esteja encaixotando. Nós vamos precisar fazer essa reflexão continuamente. Ela tem que ser norteadora, porque as pessoas também são diferentes. E a gente quer dar espaço para a criatividade, para aquilo que o outro tem para trazer, né? Então, nesse contexto, as competências em enfermagem, elas englobam conhecimentos construídos por meio da interação dos sujeitos e dele com o mundo na prática social. As competências no currículo de enfermagem, ela fala sobre habilidades desenvolvidas em saberes, inclusive procedimentais próprios da profissão, porque são necessários também. E atitudes que são aprimoradas nas relações humanas, e aqui vai trazer um pouco da parte interprofissional que a professora Suzanne vai focar. Então, a formação por competência, segundo Pinto Sarmiento, ela é uma forma de melhorar a aprendizagem do estudante, estreitando a brecha entre educação universitária e prática profissional. Isso foi uma tradução própria, então, se tiver alguma coisa que tem em espanhol, incide sobre a forma como são construídos os conhecimentos. E aí, Pérez ele traz uma coisa muito importante. A gente já falou que ela não é necessariamente uma pedagogia pragmática, ou seja, prescritiva, recortada, mas que para ela funcionar, ela precisa disso aqui, ó, métodos pedagógicos que guardem coerência com seus objetivos. Eu não consigo trabalhar competência crítica falando para o meu aluno de forma unilateral. Por isso os métodos são importantes. Por isso entraram aqui as rodas de conversa. Por isso entraram os ciclos pedagógicos. Por isso entra a simulação. E aí a professora Suzanne vai falar sobre as possibilidades que a gente tem com a simulação de abordar competências macro, porque você consegue trabalhar diferentes perspectivas. O aluno está organizando o pensamento da parte cognitiva que ele tem, ele está agindo, ele está conversando com o colega que é dupla dele na simulação, ele está interagindo com o ambiente, com o paciente que é simulado, né? Enfim, sendo uma pessoa, um manequim, e ele está realizando algum procedimento. Percebe que é uma estratégia muito completa? Então, o que a gente vai fazer é advogar pela simulação. E a escola tem uma estrutura fantástica, já teve curso sobre isso, e nós precisamos cada vez mais fortalecer a simulação. Inclusive, a OMS ela fala da simulação, acho que desde 2015, né, Lu? O quanto que é importante consolidar nos cursos de enfermagem. E aí, a simulação é um ótimo caminho para fazer isso. Essa é uma fotinha nossa, from 2017. E aí, como que a gente desenvolve competências para o currículo de enfermagem? Nos Estados Unidos tem um documento que chama The Essentials, e eles trazem uma lista de competências que é esperada para o enfermeiro naquele país. No Brasil, nós temos, e aqui eu trouxe a resolução 573, porque ela é mais completa que as DCN 2001, e provavelmente as nossas DCN serão este documento aqui, né, que foi feito em 2018, e ela traz também as competências do enfermeiro para o Brasil. Então, ela já fala sobre o termo competências, e é por isso essa minha fala. O Essentials tem 10 domínios. Os domínios falam sobre conhecimento para a prática de enfermagem, o cuidado centrado na pessoa, saúde da população, a enfermagem como disciplina, né, a educação nesse sentido, qualidade e segurança, as parcerias interprofissionais, aqui destaquei já fazendo um gancho para a fala da professora Suzanne, encerrando a minha em breve, a prática baseada nos sistemas, o apoio da informática e das tecnologias do cuidado em saúde, profissionalismo, e o desenvolvimento de liderança, o desenvolvimento pessoal e profissional dos enfermeiros. Quando a gente vem para as nossas, aqui no Brasil, nós temos 5 núcleos de competência. Um versa sobre o cuidado de enfermagem na assumem cargos de gestão no serviço de saúde. Nós preparamos os nossos enfermeiros para assumir esses papéis de liderança, né? Educação em saúde, desenvolvimento profissional em enfermagem e investigação, pesquisa em enfermagem e saúde. Das DCN 2001 para a Resolução 573 de 2018, a gente partiu de 33 para 47 competências. No Essentials tem uma lista maior, e é muito bacana olhar os dois documentos para ver como a gente pode elaborar competências de formas diferentes. Não existe uma receita. Eu não tenho nem a audácia de trazer aqui como a gente elabora competências. Fizemos texto sobre isso, né, Lu, da Sociedade de Enfermeiros Pediatras, para essa área, mas nós temos diferentes formas de escrever as competências. Então, é um trabalho que o professor vai fazendo continuamente, e eu convido para a leitura dos documentos. E aí ele traz novos enfoques, né, educação em saúde, pesquisa científica e formação docente por meio dos cursos de licenciatura, que foram excluídos daquela minuta número 5, que foi apresentada pelo Ministério da Educação. E eu sei que teve esse movimento na escola, fizemos lá também nacionalmente por meio dos conselhos de enfermagem, né, para refutar aquela minuta que excluía o termo do SUS, excluía o aspecto público da saúde no Brasil, saúde como direito, excluía a licenciatura. Então, isso é contraditório, inclusive, às discussões ampliadas de 2018. Por fim, não quero me estender mais, a gente tem alguns destaques, né, das competências, e elas versam sobre pontos importantes. Processo de enfermagem, a SAI, que a gente ainda não conseguiu consolidar. Desenvolvimento e validação de tecnologias para a saúde. A escola é um polo produtor de tecnologias de qualidade importantes, e aí, quando a gente faz para a educação, a gente também consegue fazer para a saúde, né? E se aproximar disso. ênfase na atenção primária e nas redes como orientadoras do Sistema Único de Saúde, autocuidado e saúde do trabalhador, gestão, atuação política da enfermagem, que é uma coisa que não aparecia no DCN de 2001, fortalecimento da prática baseada em evidência e educação em saúde e na saúde. Né? Então, em saúde para o paciente e na saúde por meio da continuada e permanente. Aqui eu fiz alguns destaques. Essas são as competências, por exemplo, do primeiro núcleo. Então, em azul, eu coloquei alguns conteúdos, por exemplo, que a gente poderia aprender para desenvolver uma competência, que é algo mais macro. E aqui em vermelho, então, assim, você percebe que as competências elas são descritas como verbos, próxima de objetivos, mas não são objetivos fáceis de alcançar. Você tem que mobilizar muita coisa para fazer uma competência. Ou seja, para o estudante desenvolver uma competência dessa, são aulas, são imersões no campo, são discussões, são palestras, conversas, simulação. Então, não é algo fácil. Por isso, ela não é recortada, por isso, ela não é pragmática. E aí, aqui, eu já fazendo o gancho da professora Suzanne, né? As competências aparecem, a parte interprofissional e multiprofissional, tanto na competência de cuidado de enfermagem, quanto na de gestão. Só que ela não usa o termo interprofissionalidade. Ela vai aparecer como um princípio da formação dos enfermeiros. Olha como isso é grande e a gente ainda está um pouco longe, porque disso também dependem os nossos colegas da saúde. Nós vamos fazer uma grande articulação. E a professora Suzanne vai falar sobre isso. Então é isso que eu queria apresentar para vocês bem brevemente. Agradeço muito o tempo de vocês em me ouvir e o convite mais uma vez.
I think it is on. I am holding back tears. This is my first time back in a classroom since March of 2019. I have been entirely remote. I'm on leave this year, and Canada wouldn't let me in. I am a resident in the US with my husband, and during COVID, I could not get across the border. So happy to be here, to be with you. Obrigada, Deus, Deus sabe. And Natalia asked me this morning, do we do competencies in nursing in North America? Yes, we do. But with her presentation, which she kindly translated to English for me, I understand what she was asking. And it is a heck yes. We are doing this in depth as nurses in Canada right now, looking at our part in systemic racism in our own profession of nursing. I am a white settler. My grandparents immigrated from Europe to New York City in the early 1900s from Italy and Germany. I now have immigrated to Canada and am a dual citizen of both. But we all belong to the same world. And COVID has taught us that my health is your health. And unless we protect each other, we cannot go there. So I'm excited. I was taking a million notes to connect. Think for just a moment. I have slides just to have slides, but first, why did you come today? What are you hoping to get out of our conversation? And why did we move nursing education into the university? I am old enough now. I was new in the late 70s, early 80s. We were still fighting to have nursing in a university. UBC just celebrated 100 years in Canada. It was the first university-based 4-year nursing education program in Canada. And it was a fight, and it's still a fight. So we moved it in to manage the competencies that Natalia just presented. We are not robots. Robots are handing out medications. They are managing things in the operating rooms. You can teach a monkey to do those types of things. Nurses are critically thinking, socially minded individuals with a foundation of knowledge. So I want to start at the theoretical research component and then move on. First, a few fun things. In Canada, we always begin with a land acknowledgement, and I am grateful to live and work on the traditional, ancestral, and unceded lands of the Semiahmoo, Musqueam, Stolo, and Tsleil-Waututh peoples, who are part of the Squamish nations and Coast Salish peoples. And it's so many peoples because I live right on the border of British Columbia. This photograph is actually of Canada. At low tide, I could walk into Canada. And the peoples there from Alaska down to Northern California were all the same peoples, indigenous peoples, 10,000 years ago. In British Columbia, we have 255 plus tribes of indigenous peoples, including on the island. The land acknowledgement, University of British Columbia, is with the Musqueam territories and people. And we have very much incorporated them into the university, especially the past few years. The Okanagan is our second campus. It's in wine country. So if you come to British Columbia, you need to visit there. And I also just disclose, I have written textbooks, I sit on boards, I have received some funds from these components, but I'm not selling you anything. The arrow is pointing to the mainland and the UBC campus, but this is how large Canada is. And so many of the presentations yesterday, I'm thinking rural and remote. We have many nurses and peoples that need care that are rural and remote. And we do have all 4 seasons. Our location in Canada is not like the rest of Canada, minus 32 and feet of snow. We're on the ocean. We will get snow once, twice in the wintertime and it's gone. But the mountains are 1 hour away. So you can ski and hike and do whatever you like. And to me, it is the most beautiful place in the world. I still pinch myself every day. How did I end up here? Obrigada. It is such an honor to be back. Thank you for inviting me, for having me, and indulging my ignorance in not being able to speak Portuguese. Next time I come. So I wanted to just talk a little bit about it's back. Okay. I've created some open education modules, but I'm going to tie them to how we use them for I'll try a new one. Yeah, that was red, so I think the battery was going on it. I'll talk a little bit about the theory piece, and actually, Natália, the theory for nursing education pulls in a lot of what you were mentioning, and then introduce you to the newer healthcare simulation standards of best practice, which I talked about yesterday. I have lots of QR codes in here, and I will share these completed PowerPoints so that you can all have them. For us, during the pandemic, we had to entirely pivot, like many of you, where we began teaching online, remote simulations. I mentioned yesterday, we as a nation in Canada created 60 virtual simulations for nursing students. They are all evidence-based practice. They are all tied to competencies and how we evaluate nursing students where we're at. We also began telehealth consulting. This was as an educational practice, so similar to what we saw yesterday, but also throughout North America, Canada, and US, we provided patient care that way. I've been fighting for that for 20 years. I was a La Leche League leader. I spent hours daily on a phone as a volunteer walking mothers through breastfeeding. If I could have seen them, so much easier. I think we have to be considering this viably. What is the barrier for telehealth? What makes it not easily accessible? De nada? I don't know what it is in Portuguese. Dineros? Money. Who will pay? Who is qualified? And then, privacy and credibility. We have quite a few non-licensed practitioners offering telehealth. What I'm most struck by, because we've done the virtual and augmented reality too, has been the creativity of faculty. So years ago, I took over the nursing education courses at UBC, and everything Natália was talking about, self-directed learning of our students. How do we engage students in the learning process and then get feedback to change? I had the gift of teaching graduate students, so all practicing nurses who are becoming educators. So they're bringing all the clinical practice that with undergraduate education we have to be focused on. But we created a community of educators. So what that means, similar to interprofessional, is destroying the hierarchy. How do we get rid of that power? Interprofessionally, doctor, nurse, aide. In the classroom, faculty, student. How do we become equitable? That has to do with grading, marking. That has to do with how people pass or fail. And it has to do with a more open mind. It's hard. It's really hard to do. So this is my clinical expertise area. And over the pandemic, I wrote lactation as a form of health promotion. I've been doing breastfeeding and lactation care for 35, 40 years now. And it wasn't until I came to Brazil till I realized, you know what you're doing. In North America, we do not. But with all of the updated science as nurses, we now know that breastfeeding is a global health promotion strategy. It's saving the environment. It is allowing for parent and infant's bonding and relationship. And health-wise, we just know for the parent and the infant. The hard piece is parents have not been supported to meet their goal. I had 30 nurse practitioner students. I asked, who's breastfed? Both hands went up. How many wanted to? Every hand went up. It was assumed you're a nurse, you know how to breastfeed. They got no help. So that's where the system has failed. And if we failed with our health professionals, because doctors, same thing, how are they going to help patients or feel confident about it? So when I had two wonderful faculty from Guyana, and it might even be Maranga area. Okay, two pieces. First, I came to Brazil in 2013. Bill and Melinda Gates grant, the Neo Baby Friendly Hospital Initiative. 10 sites that we had, led by Tayela, who was a student here at the time with Carmen Soshi, and experts from Sweden, Canada, and Brazil. And that was my introduction to breastfeeding here. I visited 10 human milk banks. And in that time, with that research, I then had two postdoctoral students from Brazil come. We did a scoping review. So this is an open access of our published scoping review. And we found out what health professionals were not being taught about lactation. So what we wanted to do was provide open education modules that would allow them interprofessionally to have foundational knowledge, the basics for lactation. We wanted to instill confidence. And so we're using it for nursing students, medicine, midwifery, physiotherapy, pharmacy, dentistry, and they were created in our anatomy and physiology lab as open education modules. In Canada, especially West Coast right now, we are looking carefully at diversity and inclusiveness and equity. I am training myself to say parent because every parent identifies as female. And so these modules were created interprofessional target with body neutrality, so trying not to overdo which gender they were, to normalize breast and chest feeding as the gold standard, and to represent diverse peoples as not only patients, but practitioners as well. We just took a deliberative narrative case study approach. So it's a simulation model, but and then very visual and a game. It's something that students, learners could sit down to. So the other hierarchy key, no faculty, students. It's facilitator or guide and learner, because we are all learners. These are the 5 resources that we made. If you just Google me, Suzanne Campbell, my website at UBC, or go to the UBC website, all of this material is there. But I want you to look at the list of acknowledgements. So part of what Natália was talking about with competencies, and if we truly want to move to interprofessional, we need to include all the disciplines in creation of cases, in feedback on it. So I have midwives, physicians, physiotherapists there. The midwifery students actually put together the games, and patients. We had external colleagues, Ministry of Health colleagues, all participate. And the undergraduate student who is in pre-med had no knowledge about breastfeeding, read through and edited everything. So her perspective as someone who knew nothing about it was very helpful. And this is just another acknowledgement. So all of the illustrations were done by students. Olivia and Paige, students at the time, and one of them is at Oxford University right now studying medical illustration. This is part of the representation of the diversity, equity, and inclusion, and we have, careful language formatted. When I got to UBC 10 years ago and was teaching an obstetric course, where a student in the back of the room challenged me and said, what about transgender? What about this? What about that? I started changing my language and being more open and recognizing the diversity of families. We can have 2 mommies and 2 daddies today. We know there are key elements to student-directed learning, and some of these you mentioned, Natália, that we have content that is evidence-based, science-supported, that it is flexible, that there's some form of role models. So in the gaming and the open education, that can be the practitioner talking back and forth. But in simulation, it can be a faculty member or an older student. We want to give students resources with these modules so they can go to a reference, they can go to a website and look up protocols from Ministry of Health and find the scientific proof for why this approach fits. We want them to have fun. It has to be engaging. They want to have to participate. The knowledge, skills, and attitudes are all very important to take into consideration. So I have to just mention a minute. This is Nicole Bernardes, and I'm trying to think of where Nicole was from. She's now immigrated to Canada. And those are the lactation simulation models that we used. And Lactessa Tyson, that's my doll. I used that for my dissertation 30 years ago. So the way these were developed is very similar to serious games here, I think. You have an interprofessional team, you bring in community partners, patients, families, you develop learning objectives specific to that scenario, which has a key topic and a case and a storyboard. We use PowerPoint slides for the storyboard. So when you click through on the game, it's just a new PowerPoint slide. And then we had it reviewed. So we had faculty look at it. We had a bigger team, 30 people, with faculty, students, practitioners, and patients. And right now, when you go through this game, at the end, you can go to a survey and give us feedback on the heuristics of it. So some of the students yesterday were talking about getting that. That's important to do. I think I had 600 responses right now. So these games have been live for 2 years. Just to give you a visual storytelling, we have the little drop of colostrum. Colin is the host for the game and walks you through, and when you have questions, you talk to Colin, and then the family scenario there and what the learning objectives were. So for all 5 modules, these are pieces in them. With the 5 modules, we divvied up practice settings to get at interprofessional. And the prenatal clinic, hospital setting, a home visit with a slightly older child, and a midwifery clinic. And the basic objectives are all right there. Prenatal, it's anticipatory guidance. Do they understand infant cues and feeding? How do they start breastfeeding right after birth? Our second module is a cesarean section and doing skin to skin. Very controversial, but role modeling again, right? Giving practitioners an idea that this is possible, healthy mother, healthy baby. And then how to support parents with effective feeding, how to tell the baby's getting enough, growing well, and how they manage the milk supply. Do they understand supply and demand? There's a health history checklist, and this one slide here, we are creating 10 virtual game simulations with CyberPatient with an avatar. And actually, this slide is the whole foundation for it. They will use the modules as pre-briefing for simulation, and then they will go to the virtual game with the avatar and provide care and get assessed. How much money did it cost? And did they do it right or not? And if they don't do it right, the parent and infant have problems. So this is the scaffolding. I think as nurse educators, it takes a lot of time to develop these, but if they are done well, we can build. You can have a class that introduces, students do these modules, they get clinical knowledge and they're experiencing. Then they come into the sim lab and they practice. Then they go to clinical practice and they have live patients. So it's all preparation. Why did it work? Look at all the people, all the different university degrees involved, the multidisciplinary team. And then throughout the game, we based it all on the baby-friendly 10 steps, which is global. We used the love method of communication, and this is a trauma-informed. It just assumes everybody has been exposed to trauma. And it's a listening, observing, validating, and explaining, I think are the LOVE. The OR method is another. The green flags students hovered over when a patient responded, and that's everything's going well, and explain why it's okay. The red flag, oh, maybe a problem. What else do you need to know? Things like dehydration in the baby. And the closer look, the magnifying glass, they could actually look over the nipple and see the damage from mispositioning. So how are we incorporating these now? Yesterday, my midwifery colleague taught my 3-hour class to the 150 undergraduate students. We meet with them in class, do some demonstration with the dolls. They go and do the 5 modules, and then they will come into the simulation lab, and they will have a standardized patient or a mannequin that they will meet with. And so that's the role playing. How could they be used? All of that, and then the OSCE, the objective, structured, clinical exam. We use that with nurse practitioner students, not undergraduate right now, but it could be clinical practice. They're out in the real world, they're practicing, they can go back and review the modules if there's something that came up that they remembered was there. But what I'm going to share with you is how we used it for telehealth. So I mentioned the telehealth as a possibility for interprofessional simulation practice. Again, COVID. We were meant to bring midwifery, medicine, physiotherapy, and who am I leaving out here? Yeah, I don't know that we had the pharmacy student. There were 4 groups. Social work? Maybe social work. They were meant to come to the simulation lab in groups and do this with a standardized patient. COVID. So we made it virtual as telehealth. We had the students sign up. We put one of each discipline in, and they were in a Zoom room online. So this is what I hope to describe for you in a little more detail. We know we still needed to be teaching. We still wanted the interprofessional experience for them. Hard to get. And we had them then attend this virtual lactation simulation lab. They got the case when they came in the room, like the nurse reporting off. This patient was discharged early, 24 hours, first baby, and trouble with the latch, having nipple pain. We took the scenario we meant to do in the lab and tweaked it. We had a clinical facilitator, 1 faculty, and then the rest of the research team behind Zoom making everything go. And then my student, Thayanthi, was the patient with the lactation model on. And I think she was 7 months pregnant at the time we were doing this. but all online, right? We only see from here up. And we had the students first do the first two open educational resources, prenatal guidance and after delivery. So where did this fit within those standards? And I don't think you presented this list of the standards. These are the new ones. They came out November 2021. They've been out 1 year. They are internationally and interprofessionally accepted. The first group, and they should be in Portuguese, yes, okay. They were initially through INAXL, which was Nursing Association, and in North America, physicians won't read anything from nursing. So this is with the Society of Healthcare, which has many more physicians and interprofessional, and every interdisciplinary group has signed off on these. I was a reviewer for 2 or 3. Pre-briefing is the new one, and professional development was also new. So there have been studies on the use of virtual simulation. Those are the games I was talking about. Very similar to your serious games here. And applying theoretical concepts works well with that. They're very, but I think the issues are around debriefing and how faculty guide students with them. And we have seen learners become more confident, self-efficacy, and they enjoy it. They are engaged, they have fun playing. We had initially about 10 to 20 virtual simulations through CanSim pre-pandemic. Now we've created 60 more. During the first year of the pandemic, there were over 2 million users. They're totally open access. They are in English and French. And like for my open education modules, I'm looking to do some translation on them, and Portuguese will be one of the first languages, and Spanish and French. And with the virtual 10 scenarios, we're using videos with Google Translate, so we might be able to close caption them. So, I mean, we all need to be thinking, how do we share our resources? I've shared your Serious Game website. And, you know, if there was a way to translate, I think it would be used. So this is just some of the effectiveness. It is a disruptive innovation. It's different from that technical, autocratic, here's the information, regurgitate, give it back to me. We've explored a variety of uses for it, and Natália and I have worked a lot in the area of communication. It's a soft skill, it's foundational, non-technical, but without it, healthcare falls apart. And the effectiveness of telehealth simulation resources has specifically been found to clinical practitioners. So here's the other piece, because in the presentations yesterday, some people are focused on practitioners, not nursing students, and that is good. All of our materials, our communication tool is aimed at learners and practitioners. I think it's not either or, it's both and. In the health literature, I think that this will resonate with you. We're seeing health educator burnout. We're seeing students coming in less confident because they haven't had the classroom clinical piece. And I know our practice partners have concerns and are having to do a lot more for orientation. So how do we up for this. Laugh because in North America, I have to put up a warning sign. To all of you, it won't matter. It's a breast. North America, that's a, illicit picture. Unfortunately, my good friend Anna had to close this company. She was selling these lactation simulation models for the past 5 or 6 years. I have 4 of them at UBC, and I will hold them for life. They are so realistic for your clinical people that want to be lactation consultants. They're wonderful. But guess what? The one that Nicole was holding, I think the puppet with the breast, that's a Brazilian made. I ordered it from her small village, a woman that makes them. I got 2 puppets and you can crochet a breast. It works just as well. So what happened was with the surveys from the open education modules, we got good feedback. It was low participant burden, so they didn't feel it was too hard to do. They felt it was a realistic enough environment or virtual environment. And we looked at some of the implications for future education. Faculty gained insight into how to develop these, how to use them in class, and how to evaluate student learning from them. I also had a pre and post knowledge test that's fitting a little bit into the knowledge, skills, and application. The advantages for the telehealth simulation was the scheduling. It was really easy to schedule students that didn't have to be on campus, travel, park, public transportation. It was very easy for the standardized patient to debrief with the 4 students, and then the faculty, standardized patient goes away and the faculty could debrief. And then as a team, we could observe and say, what went well? What do we want to change next time? So it was all this internal feedback during it. And it minimized that cost for travel. The biggest issue is the inequity related to Wi-Fi access, because for Zoom, you need broad bandwidth. And some of our rural partners and students couldn't do it, and you need to be on camera. So there are a lot of reasons to persist in interprofessional simulation. The camaraderie, what we learn about each other to create these, providing clinical interactions, decreasing the hierarchy, normalizing that we should work as a team, and it enhances communication for sure. It also takes us out of our own ego and reminds us we are here for the patient and their family. It is that person-centered component. Just as educators, we are here for our students and our learners. It's not about me. That's a hard lesson for me. It also gives them clinical learning opportunities. They're thinking through cognitively, they're vicariously observing, and you work as a team and it exposes students to the clinical environment. Some of the barriers are integration. First of all, faculty need help in identifying these good products, because for us in Canada now, there's hundreds out there. How do I choose what fits my objective for that course for those students? And then how do I debrief? Where does it fit best? Where does it go? I think we need a higher level of the educators to be figuring this out and sharing the broad curriculum. The logistics can get very tricky for the telehealth. Is everything working, technology, and the lack of support. As I'm talking, it's very similar here in Brazil. One person runs the sim lab. it took 3 faculty and a standardized patient for 4 students for an hour and a half simulation. If you have 1,000 health professional students like we do at UBC, how do you do that? Where are the resources for that? And so the costs are human, equipment, and personal as well. I'm trying to think the other pieces that I was leading into here are more about how we work as faculty to peer lead debriefing. So I have some resources that I think could be helpful down the road. And just, I mentioned time management as an issue. When we had planned this for the simulation lab, we had 4 rooms, faculty, clinical instructor, standardized patient, and then 5 students at a time. And it takes us 3 days, 8-hour days, to let every student have that experience. Is that necessary? When I first started with simulation, I took a class like this. I live streamed from our simulation 2 doors down, 4 students with a patient. So I had my lab person controlling, someone in charge in the room. Everybody was watching as the case unfolded, 10 minutes, and had questions. At one point, postpartum hemorrhage, they were not massaging the fundus. And one of the students in the classroom said, they're not doing it. I said, you be the midwife. You go in and help. So, and then the students came back to the classroom. We debriefed as a group, and I taught the rest of the content for the day. So that's where not getting into boxed thinking, yes, no, right, wrong. How will it best work for time, resources, and learning? What fits best? There are some ethical approaches. We're very much talking about psychological safety for our learners. So that's part of the who owns knowledge, how do people feel. In simulations, students can feel very unsafe. They worry about being judged, being shamed, not knowing the right answer. So presenting it as learning. It's a learning opportunity. It's a safe environment. And then how to hold everyone accountable to being respectful. Much more respect here in Brazil than I see at some times. And this is just a little bit about that difference between trust and feeling you can trust a faculty member, and then the psychological safety component of this is especially if you recognize an unsafe situation in the clinical situation. When do you speak up? How do you help students feel safe to speak up? I'm concerned. We have cuss, concerned, it feels unsafe, and stop. And there are just toolkits and other components there. The other piece, again, this is just if you want to explore further, we've created communities of practice to support each other as faculty. And even though these are all, the top ones are all nursing related, there's also the Society for Simulation in Healthcare, and the Simulation Canada is just nurses. Those are the interprofessional ones. And I'm curious too, I know you have a Brazilian rig, but whether locally there are some groups that you might do that with. I'm always pushing whatever you are doing needs, your presentation this morning needs to be published. These are just some suggestions to go, and there's a whole variety of ways to approach this. No right and wrong. I gave you one example from the open education modules, similar to many of your serious games, how to integrate telehealth type simulation. And I think you're a little ahead of the curve than what we were doing with the telehealth here. And making sure you're following the best practice standards as you do that. There are a lot of benefits to the open access modules and the telehealth simulation. The open access modules, students might do before a class, but they're not in clinical for a month. They can look at it again right before they go into clinical to refresh their mind. It takes 10, 15 minutes to go through. The other benefit is you can represent evidence-based practice and have resource links with it. The challenges are it's staying relevant. Literature changes, research is our big one right now is mastitis. Thankfully, that wasn't in our earliest ones, care and protocol for mastitis. And I need to find someone here who knows something about that in Brazil, because we totally changed how we're managing it now in North America. And the directions. So it's not just faculty where in the pedagogy does it fit in curriculum, but also for the learners. How am I expecting you to do it? How do I know you really did it? I was so naive 10, 20 years ago and had quizzes before class. And I realized they had a party night the night before class. One person would go through, they would write down all the right answers. Everybody else would fill in their quiz and get 100 and be done. Quiz is meant to be a learning opportunity, but and then the lack of interaction, and Lou and I were talking about that, not having conversation, debriefing fully, individualized learning. So again, these were foundational knowledge. I am passionate. I presented this definitely all across Canada and at a couple of interprofessional things, but we did try to maintain equity lens. We used evidence-based practice global, WHO, UNICEF, baby-friendly standards. It was contextually rich. There's a lot to have fun just zipping through. It's a lot of pictures. I mean, I don't think the words will be all that hard. And it did provide role modeling of a respectful primary care practitioner sitting one-on-one, acknowledging parents' concerns, helping them identify what was going well. Again, it is only foundational knowledge. These other 10 cyber patient avatar-based ones will be moving ahead with more clinical knowledge. And so I'm trying to think, that's my website, the QR code for my website and where those are listed, but it did provide us an opportunity for interprofessional arrangement. So I'm recognizing this this was my interprofessional simulation piece. It didn't go heavy into the theory and research. So maybe we stop now, answer questions, and these were just other resources. I don't want to go too quick. I mean, if you get to there, most of the rest will be there, but there's the standards, which I think might have had a link previously. There's resources for researchers on an Axel. I think that's the instrument page. So any of you doing research in simulation, go look at the different tools that have been validated. And then there's this whole evaluating healthcare that has a great facilitator competency rubric that we're starting to use as part of nursing education for people specializing in simulation. Here's your Portuguese dictionary, everything you ever want to know about simulation. And I'm thrilled because the 2.1 is the second version. They held off on the Portuguese translation to the second version of it, so it's totally up to date. A lot has changed from the 15, 20 years I've been involved in an Axel, but I think we're making progress with a common language. That's what the dictionary allows. And then here's your ticket at the door. So talk about engaging students. You present the objectives in the beginning. You say, think for a minute, write down what you hope to get out of this. How will you apply what we've just talked about with use of open modules, integration of interprofessional, does it fit anywhere in your classes, and create a SMART goal. I spend a lot of time personally and with learners creating SMART goals because getting them specific, and today, this is all about you. This is for you personally, what do you want to get out of this? And then the question is, did we meet the objectives there? And discussion and questions. This is what I thought I would start with, and I'm only going to go to parts that are relevant because I think the beginning was very similar. So this, I just wanted to talk about theory and research a little bit. And all of the open education resources and other components, we integrated learning theories. And they're all highlighted because those were ones I didn't have references for as I was fixing it on the plane, and I was going to do it before now and I didn't. So I will add those. These are the basic theories we identify. I think they will all look familiar to you as teaching and learning. And basically, we're looking at that difference between behaviorism and constructivism. But from Natalia's presentation, the humanistic, critical, reflective, we are using post-colonial feminist theory to describe exactly what you were getting at. I think they're very similar. But we know with simulation, a lot of it is colds. As nurses, we are practitioners. We need to get our minds thinking and evaluating and then doing. So that concrete experience, doing and having it, reflecting and reviewing on what we did, conceptualizing it. Where does it fit and everything else I know? And then planning and experimenting different ways of doing it. For simulation, you might be familiar with Jeffries' model. It's called the NLN and Jeffries now. Not very different, right? We have, thought that worked. The teacher and the student, what types of educational practices, and what outcomes are we looking for? Is it a skill? Is it learning? Is it critical thinking or increase in self-confidence? This is the one that my colleague Karen Daly and I created back in 2008 when we wrote our first text. And the thing that I think is a little bit different about it is we were already recognizing what the learner brings to learning. That's the humanistic approach. That's the who owns what knowledge. And for us, the indigenous knowledge, the knowledge from groups who have been marginalized and not respected, our refugees and our immigrants, the knowledge from people living in lower socioeconomic, experiencing poverty, and food insecurity and housing insecurity, all of that affects what our learners' experiences have been and how privileged or not they might be coming into the learning environment. It also affects how they learned as children. How did teachers treat them? What was their experience in a classroom? Did they feel threatened? Natália and I have been studying the communicating effectively, but we identified these 3 key areas to be a good nurse. You need to be able to think critically, intervene therapeutically so that the patient is okay, and communicate effectively with patients, families, and professional members. And if you don't, then the patient has a problem, that failure to rescue. In simulation, the big S in the triangle, you can do it again. Students can practice. And we use simulation for remediation as well. Anaxel has developed research priorities. So for those of you developing or working on your projects, I think the due date for the Deborah's Fund grant has passed. They have a $1,000 to $2,000 US grant annually. And if you target it at these research priorities, on that QR code, it takes you to the About Anaxel homepage. At the very bottom are these research priorities, and then you can click and look. But Interprofessional is there, Evaluation Tools is there. The briefing, how I'm using the open education models, and then things like medication admin skills. I have a PhD student now creating a virtual game, but it's going to use eye tracking. So he is looking at how the nurse examines the medication, the expiration date, and tell exactly where, and provide them feedback. And it will be used on new graduate nurses. So, Infirmigen, Nueve, just graduated. And he's working with a hospital partner who's helping to pay for some of the development. We're also using simulation in our practice settings. To me, that's where most interprofessional simulation is happening in our practice settings. The problem, nurses are not involved in the planning. Doctors come and say, "Oh, nurse, can you come and do this with us now?" Like, I have a patient load, this wasn't planned. So we have mostly nurses directing the simulation labs, and they are solving that. The virtual gaming is huge. And I think if you look at the Canadian literature, large amounts. At that Anaxel website, the newest journal issue is all diversity, equity, and inclusion. Lots of virtual gaming options incorporating that. So common issues are, we don't show it works. We can't demonstrate impact of the simulation to clinical practice. We do knowledge, we do hands-on skills in the lab, but does it affect care of the patient and patient safety outcomes? We don't really know. And then when do we time it? How do we use it? And how do we define that translation of learning to better outcomes? So to improve the research rigor piece, this is the part I thought would be helpful. You have the link already. Adam Chang did this paper that took the major reporting guidelines and identified how we can use the model to target simulation. So he's just given a list of what you can do to improve the rigor of your research and get it published. I mean, that's sort of the ultimate components of it. Things like just putting simulation in your mesh term. That way, when people are searching, it pops up for them. Incorporating a theory. And when you use a theory, you don't just say in the introduction, I use this theory. You show how you connect the theory to your method, to your analysis, and then to your results. So bringing it through the writing and then giving specifics. What type of simulation? Who were the experts that developed it? Was it peer reviewed? Was it piloted with student feedback? Those just all enhance how you do it. The other piece for more observational studies in epidemiology, this is just how to strengthen those reports. So this is where those of you who are still designing your research might want to incorporate just a few qualitative questions. Have the participants ever been exposed to simulation? What is their background and experience? And how generalizable are your findings? We know that there are gaps in education research. I think we covered a lot of this. And I say faculty development is key. Knowing that even you faculty sitting here, like, this is a gift of your time to be participating, because you have so much that you're already doing. This is more to administration to be saying, how do we calculate into faculty workloads, development of cases, and integration of the pedagogy, or have someone in charge that's part of their job to work with faculty to create those pieces. In Canada, it's not being done well. We are trying. I think we all keep trying and share how it works. Here are some of the barriers and enablers. So how we're fixing the faculty training. In Canada, we have a simulation nurse educator certificate, 4 modules, 8 weeks each. We have over 100 nurse educators across Canada certified as simulation nurse educators. What do we give them? I teach 2 of the modules, the basics. Most of what I covered with you today is bottom line of what we are teaching, so they know what standards are. And then we have just hired in a new coordinator for simulation, an associate professor of teaching, and they are leading how we integrate simulation in, working with faculty, figuring out the curriculum. That's part of their job descriptions. Because right now, with so many students, we are using simulation as clinical time. About 25% of our clinical hours are simulation. This is where a very old lab, your lab puts ours to shame, but we will have a new building 2024 with a state-of-the-art lab. So these were just key elements that I pulled out of what you want to consider in developing your research, and then what you want to report in your manuscripts. And again, those resources are the same from the previous, and just some of what Natália was referring to with the competencies are quality safety education in nursing in the US. The AACN has done a ton around this, but when you look at all those qualifiers, that's interprofessional. Those are the key role areas we focus on for interprofessional. I mentioned the evidence-based practice and how we can look at the knowledge translation into those areas. This is what I wanted to make sure I shared with you. In Canada, they have been focusing on interprofessional health education and development for 30 years. They are really the leaders in North America. And they have a whole collaborative with specific goals. The module 3 of our simulation nurse educator is all interprofessional, and we just teach based on this model. So I will, this link will take you to the major website, and this is a group, these two faculty, OT, and our executive director of our Canadian Association of Schools of Nursing. So with the competencies, this could help. We have integrated interprofessional competencies into all the health professions in Canada at a beginning level, but they are part of our national registration of health programs. So there's a lot of conversations we could have around this. I already introduced those pieces. The other one I do want to say, so this interdisciplinary lactation care is another example of, I was an editor and a chapter author in this, of how we've incorporated the interprofessional piece to lactation care. The second edition just came out. A year and a half of work, 800 pages. There are 2 simulation type case studies for each chapter. So we have over 60. That was a big change we did for this one. Available to instructors if you call and ask for a copy. And then there's the whole world. I am not here yet. I tend to get motion sickness. I have done some, and they've gotten better about that, but it is being used a lot in research in Canada, more in medicine again. I don't know for nursing if you're using any of the virtual or augmented. Okay. So for communication. And the rest, I think I was going to take some of those other pieces out. But no, I think that this was just, if you go to the website, you will see, and I say my website, it's our website, it's my research team's lactation and communication, but all the things that we're working on right now are there. Natália and I are going to write the chapter for an open education book on communication for our virtual game, which we're hoping is going to be done in a month. For communication, interprofessional, foundational. I really think unless we have foundational resources, we can't do it. So there's your other ticket at the door. It was just building on the theory and research aspect. I'm going to hand it over.
Professora Suzanne, professora Natália, muitíssimo. Acho que a gente pode abrir para perguntas. E, meninas, por favor, dê uma olhada. Se tem alguma pergunta no chat. Interessante. Uau, né? Acho que isso nos faz pensar muitíssimo da nossa prática docente e que extrapola o espaço da simulação e olhar para o que e como temos feito. Né? E a gente, aí, né, quando olha para as nossas atividades de simulação, e aí então recortando um pouco para as atividades, e pensando que a gente tem usado em larga escala a Patrícia Benner, que são né, para simulação, e que são as competências para a enfermagem, acho que já entrega um pouco do quão pouco temos feito no interprofissional. Né? E aí a gente lembra que nós temos um curso de pós-graduação e que traz para os nossos corredores outros profissionais que não são enfermeiros. E queria que a professora Suzanne comentasse um pouquinho de como foram os desafios, as facilidades de trazer a simulação interprofissional. Claro que existe um espaço mais macro, né, de que um campus menor favorece, ou de que um centro de simulação único para os cursos da saúde também favorece o interprofissional. E, obviamente, tem um espaço mais micro de que é o tete-a-tete de professores de diferentes áreas trabalhando junto. Como é que aconteceu isso? Obrigada.
So it's a great question. And at UBC, the last 10 years since I've been there, we have 1,000 new health professional students in 17 disciplines annually come to the UBC campus. My first year, we were in the basketball stadium. All 1,000 students. We did small groups. We had patients up front. Now we have created 6 modules. Students have 2 or 3 2-hour classes every fall with the interprofessional group, led by faculty facilitators. So the module development, there are online learning. The examples are professionalism. The first one, basics, learning about each other. And then they come 60 into a room. I'm the facilitator. I have 8 from every discipline. They are separated into small groups at tables, and they are given a case. So we review, we might watch a little video as a group, and then each group of interprofessional has a case to work on. They respond, they hand in information online, and then as a group, we talk about it. 2 hours. How did we get there? We identified 2 days of the week, Tuesday morning, Thursday afternoon, that all the health professions had to agree not to schedule class or clinical at that time. And then figured out what students went where. With faculty, they looked at professionalism. One is allyship and cultural safety, so very indigenously focused in how to provide respectful care for patients. One is on ethics. There are actually 2 different levels of ethics. One is on digital health, e-health. I helped with the curriculum for ethics and for e-health. I used the e-health with my nurse practitioner students. We did it as a class together. It wasn't interprofessional, but so we had to work with faculty in each discipline. Where does this fit in your curriculum? And get them to be accountable to integrate it there. I think we finally have identified a faculty role as interprofessional liaison for the school, and then they attend meetings in our UBC Health is the over. So we have a practice section, we have an education section, and maybe curricular, but there are 3 sections in UBC Health that all of the disciplinary faculty meet and work together. It's not simulation. We tried and started with it as simulation. We worked on some telehealth aspects of it. I was very active in my director role because I'm so passionate about it. But I've lost track of where it is right now. And the simulation, 2 areas with nursing and only medicine are the OSCEs, nurse practitioner and medical residents. And I've done some with the lactation. The medical residents have come, or students have come to us in nursing to ask for opportunities, but it's not all of them. So the logistics of timing, when other universities I've worked with set aside Friday afternoon. Many have one big simulation a year. At University of Alberta, it saves Stan. So they have a whole community. Your EMTs, paramedics come in. Your community firemen, nurses, doctors, all are there. We did that once at Fairfield, and it was a chlorine gas bomb in an auditorium. So my students were all meeting normally for class, and this happens, and we had the moulage, and the students up front were mort, and the others, the guys came in hazmat suits. We had police, we had EMTs, we had chaplains and counselors, and it took half a day and a month of planning to make it all happen. And how I've seen simulation evolve, for me, it's always been because I love it and it's just extra and I just do it off the side of the desk. Today, I see we're beginning to recognize the value. It's very important to do, and paid positions for people to facilitate and moderate and get it together. Still overworked. Now I'm going to switch in hospital, because in hospital we use simulation interprofessional, mostly in situ, emergency room, intensive care, neonatal intensive care, and obstetrics for high risk. That's what I know, because I know the BC Women's and Children's. We, in the last 10 years, have appointed people in charge, and I think they now have staff. Much of it initially the doctors owned. So anesthesia, emergency room, they owned it. Here's funny. The rooms are owned by the hospital. In the simulation site, the hospital owns the room. The physicians at UBC own the equipment. That's why this new building on UBC campus, nursing owns, we share with kinesiology, but hierarchically, when nursing builds and has response, then we will call out and we will invite interprofessional, including physicians. Yeah. And I think here's the hard piece. I spent the first half of my career, more than half, in Northeast United States, Connecticut, right between New York and Boston, and we practice only interprofessional. My first job at an academic medical center as a brand new nurse, I was equal with the attending. They would bring me in and show me things. We would go on rounds for each patient. My voice was respected. And then I go to UBC. 30 years behind. Physicians, no respect, nobody knew what a nurse practitioner was. I've been a practicing nurse practitioner 20 years. We've had midwives and nurse anesthetists for over 100 years in the U.S. We may have our first nurse anesthetists at UBC. It's at Ministry of Health level. In the United States, nurse anesthetists provide 70% of all the anesthesia across the United States. 70%. They're capable. And many that come to that program were medics in the military services, right? So that's my soapbox. Nurses have powerful knowledge. Your graduate degrees are preparing you to lead healthcare. That's what I was thinking with Natalia's presentation. We are critical thinkers. We are the solution for the future. The pandemic in North America, nursing is at the top. President Biden understands and respects it. And he and his wife understand the community college system where we have many nurses being educated. Makes a big difference. So does that help? It's not an answer, it's examples. We all struggle.
Eu queria só acrescentar também, muito brevemente, né? A professora Suzanne traz um componente do desafio de interprofissional, acho que todo mundo aqui no Brasil a gente tem também. Queria só compartilhar uma experiência que a gente tem lá na faculdade de enfermagem, no estágio supervisionado. Aqui a gente separa a atenção primária e hospitalar, né? São 2 blocos de estágio. Lá nós temos 4, e aí em um deles, que acontece exclusivamente na atenção primária à saúde, tem um certo rodízio, não é toda a carga horária do estágio, mas tem um rodízio em que é pactuado com a faculdade de nutrição, de enfermagem, medicina, odonto, que os estudantes rodam ao mesmo tempo e eles são uma equipe. Então, formam uma equipe, ele roda de forma diferente, pequenininha, dentro da grande carga horária, para poder todo mundo ter essa oportunidade. E aí eles formam equipes de estudantes. Então, a gente tem sempre 2 estudantes de enfermagem, 2 de medicina, 2... E eles montam essa equipe, vão para a mesma unidade básica de saúde e fazem todo o estágio juntos. E aí isso é uma coisa muito interessante que eu não conhecia. Lá acontece com essa logística, então ele roda uma carga horária menor, mas é uma oportunidade importante de a gente promover dentro da universidade esse contato que é tão difícil. Por outro lado, a gente não consegue ainda articular as disciplinas. Então, a gente tem, por exemplo, igual ela falou, das sextas à tarde que acontecia essa reunião, é muito difícil a gente conseguir travar uma agenda dos professores durante um semestre usando 5 unidades acadêmicas ao mesmo tempo. É uma logística muito difícil, né? Agora, essa experiência do estágio supervisionado eu queria compartilhar porque eu acho que, inclusive, o plano de colocar simulação nesse estágio supervisionado é algo mais factível, porque são pequenos grupos. Então, só para compartilhar uma outra possibilidade também de a gente fomentar a interprofissionalidade nos nossos currículos, essa parte de logística que a Suzanne traz, eu acho que é o principal gargalo que a gente tem, né? Eles fazem, Mariane, assim, base regular. Todos os dias eles finalizam, foram para a rotina. Chegaram 8 da manhã na UBS, saem às 11, das 11 ao meio-dia, reunião de equipe, discussão de caso, planejamento do dia seguinte. Eles voltam juntos para a unidade, trabalham de novo, e os preceptores são a equipe que trabalha naquela unidade básica de saúde. Então, não necessariamente você tem um de cada profissão, né? Porque a gente sabe que algumas unidades não têm. Então, eles fazem essa preceptoria e os supervisores, isso acontece no campus avançado de Firminópolis, que fica a uns 50 quilômetros, acho, de Goiânia. Os preceptores, um de cada, os supervisores, né? Os preceptores estão na unidade. Então, o professor, vamos supor, eu tenho aluno supervisionado lá. Eu, mais a professora da medicina, a gente pega um carro, vai juntos e faz reunião de equipe. Então, os supervisores, os preceptores e os estudantes. É muito legal. Eles mantêm a estratégia de portfólio individual, como a gente já faz, né? E aí, só que as discussões são todas em equipe. Pamela.
Boy, no. It's
Just to read out, like, what's the experience of the group from Canada with simulation with the elderly?
So yes, we are using, and we were also talking about student experience of being elderly. You have the weights added here to make gait and balance difficult, eyewear that is macular degeneration, gloves that make picking things up more difficult. But we do, I don't, this is how siloed we are. I don't know what my colleagues are teaching in the adult and older adult, but Jennifer Bombush and Allison Finney are the two heavy researchers. They have teams looking focused on dementia. So I'm assuming there's some sort of simulation around working with families and patients. But more importantly, we have a patient voices community. And our students, I forgot about this, in interprofessional teams work with patient mentors. So I am a patient. I have diabetes. I've been in the Canadian healthcare system 20 years. 6 students come meet with me, go to a visit at the hospital with me, sit down and ask about what it's like to live with diabetes. We have many older adults that are health mentors. So I think that's beyond simulation, right? That's actually creating an opportunity to talk with them and then using the simulation environment to prepare them for that. So the Health Mentor Program, I think again, 5 disciplines, only half of our nursing students get to do it because of the funding and the logistics. But at the end of the year, they do a poster presentation with their health mentor. I always go goosebumps because I want to hug the mentors and say, thank you for teaching our students. You are doing my job better than I can. But I think for faculty, when I go and see the presentations, I understand the patient perception. And so for me, those lactation modules, I've been working with breastfeeding parents for 35, 40 years, starting as a nurse who knew nothing to a La Leche League leader with my own baby trying to figure it out to a lactation consultant. So I always reach out to get the patient voice or have practitioners involved who are working with patients and can get that. And that's the area in healthcare education I see growing now. So the answer is yes. We do have simulations for elderly. My final 3rd textbook, there probably are 10 in, and some of them, I don't know if we had any collaborations with Brazil. We did together the infant of the diabetic mother, Lou and Natalia and I. But there are scenarios out there. And the free virtual games, there are definitely elderly simulations there. So the virtual games we are using as pre-briefing, and this is what I found with simulation in general. As a clinical faculty, when I did simulation first, my students came on the floor prepared, and they were practicing at a much higher clinical level with much better critical thinking, clinical decision making than they had prior to me doing simulation. And it meant the hospitals, the staff, very happy to see me because they knew my students were ready. So I think that's what we can sell to our administrators and our Ministry of Health and our practice partners who are saying, prepare those students. We, with our undergraduate students, use the simulation labs at the hospitals as post-conference. Our hour post-conference, I would take students in and say, okay, tell me what went really bad today. And we would replay that scenario. The other area for simulation for interprofessional and faculty development is do simulations with clinical instructors. Have an actor, a previous student, present student, other faculty be the student. I had a student in newborn nursery give the vitamin K shot, get so nervous, pull it out of the baby and put it back in again. And I had 3 pediatricians watching. It only takes once, right? Every student after that, we practiced on a baby doll in the back room before I let them anywhere near those babies. And she was an adult learner and incredibly bright. She just got really nervous. So lots of uses, and yet no different from when I started teaching in the 1980s. We're still nurses. We're still practitioners. We're just building on the case studies and finding ways to integrate them for this new generation that is technologically savvy. Just because the technology is there, we don't have to use it. We need to use it wisely and make sure we're not asking too much of students. Another question, I think. So I hope I answered. I'm not sure if it was Rosalia.
Lidiane also asks, how is the practice of simulation with children in situations of airway obstruction? Can you talk a little bit about that? A Lidiane, thank you, Suzanne. A Lidiane perguntou no chat como é a prática da simulação com crianças em situações de obstrução de vias aéreas, se ela pode compartilhar um pouquinho sobre essa experiência.
So really good question, and in the US, our nurse anesthetists were practicing that. We had the pediatric simulators and endotracheal components. I am certain in BC Children's Hospital that they have scenarios written that they bring interprofessional teams in to work on. I don't know of any written scenarios. Natália may know. Okay. So there's one being validated in Guyana right now, so get in touch with Natália. And that's the place, right? So where you will find those, I find in Canada, especially BC, are health groups with a disciplinary focus. So our maternal child, we have a maternal child discussion group, and oh, I forgot the rural sense. I have one more thing to share with you that we're doing right now. I'm sure there's a pediatric group that is also working based on protocols, and often the scenarios are built based on the hospital or practice or provincial or federal point. And I forget, in Brazil you say states like the United States, and in Canada we say province, and so everything's a province to me. So the one other thing we're doing, I got involved a year and a half ago. The physicians, the rural family practice physicians. so very remote areas, come together every Monday night from 8 to 9 Pacific time, so too late for the East Coasters, and they do a virtual simulation together. And they invited me initially. I'm like, I'm a nurse. Why do I? They wanted it interprofessional, and that's where I learned the CUS method. I am not an OR, ER nurse. ER nurse, emergency room is what they were doing, really. And I did my best to fake it, but you could take the medications. They're in a really simple PowerPoint slide. They would put up slides of a live ultrasound of something. And so they were integrating, and they would give preparation things to people. But it was an open come as you are. And for those rural areas, oftentimes, they don't have the medication. They don't have the high level, whatever they need to treat this problem like they would in the big hospital. And they are just waiting for the helicopter to come and take that patient out of there. What do they do to stabilize? How do they manage if the patient doesn't survive? So that model, I got involved because I just wanted to see what they were doing. I think it's something that we could be using as a model globally. The other thing I thought about yesterday and today is we could be having these discussions together. Like, I don't physically need to be here. For anyone interested, on Thursday, if you go to the UBC website, we have our annual Woodward lecture. And maybe I'll send this and it could be emailed out. Also, follow me on Twitter and LinkedIn. I'm at shcampbell27 on Twitter. And I tweeted out one of you this morning, but I'm also on LinkedIn. If you search Suzanne Hetzel Campbell, you will find me. I post all these updated materials and things there. And I feel like I have more Brazilian followers than North American followers right now, which is okay. But the Woodward lecture, the other thing on top of diversity and equity is the climate change. And so we have a major speaker for 1 hour. It's 4 to 5 p.m. here on Thursday. It will be recorded. You can go to the UBC website and see any of our Woodward lectures, but they do have an online discussion afterwards that the Zoom link is sent to you. It's free registration. There is no cost. I don't know in Brazil if you're starting to look at this, but for us, the last year, especially with the pandemic and the West Coast, very ecologically minded and really thinking this climate change is all of us. You all know it so well with the Amazon, but it is global. And North America is a horrible example. We are getting better, but still a long way to go. So if you learn nothing else from here, and I just saw the Brooklyn, New York t-shirt, my nieces are living there right now. All my family was from New York. UBC website. If you learn nothing else, just UBC School of Nursing. Google it and look at what is happening there and going. We have added almost a dozen new faculty since the start of the pandemic, and they are amazing. They are global, and my dream is for you all to come and do sandwich doctorates or postdoctorates or whatever we can arrange, because there's so many resources. And I would not be here without the collaboration that I've made with USP.
Suzanne, yeah, Professor Rosalina on chat, she asked about the elderly in the simulation. She's asking for the names of the researchers you shared from UBC.
Jennifer Baumbusch, BAUMBUSCH, and Allison Finney, PHINNEY. Under the UBC School of Nursing homepage, there is our people. If you go to faculty and actually put in Allison and Jennifer, they may just pop up. And I can put you in touch with them. I don't know how involved they are teaching the undergraduate courses right now. They're more focused graduate level and the heavy researchers, but they would know what's happening with that.
Mais alguém? Okay. Professor, thank you so much. Perfect.